Okay, so hello everyone, and I apologize for a very long break. I haven't been uploading in a while. I've been quite caught up with making a lot of content for just other things and been busy with school. And I know that the mocks are like 3 months, sorry, not the mocks, school mocks are probably 1 month away, but your CI exams are probably like around 2 to 3 months away from the date of this video. Um, but I've got two videos left for clinical psychology to upload. One of them is this one on obsessive compulsive disorder, and the other one is on anxiety disorder. So I hope to complete those very soon, so then I can get started on the videos for health psychology. Um, what else? Consumer and organization. I probably will not be able to create content for those options this term. But I do hope to create content for those two for the next academic year. Okay, so let's get started with OCD. This is a very interesting disorder. And we'll start with the diagnostic criteria. Now, as I often discuss with all other psychological disorders, um, to a certain extent, everyone believes that they have symptoms of pretty much all these disorders that are in our syllabus. You probably think that you have depression. People jokingly say that, oh, this person is bipolar, or I have bipolar tendencies. But when we really understand what the actual criteria is for a diagnosis, we realize it's a lot more extreme than what you think you were suffering from. Similarly, with anxiety disorders, impulse control disorders, um, there's a difference between just experiencing certain symptoms and actually suffering from the disorder itself. So it's quite common for people to think that they have OCD because maybe you'll see a painting or a frame on the wall that's just slightly tilted to the left or the right, and obviously it is something that will make us feel uncomfortable, when the teacher is raising the whiteboard and maybe they leave like a little mark on the board. It bothers you. Sometimes the volume on the TV is not at 20 or 30, maybe it's at 29 or 28. So these little things can, you know, trigger us. But is that really OCD? The short answer is no, because OCD, like every other disorder, in order for an official diagnosis, it has, or you must experience two main symptoms, which are actually included in the name of the disorder itself, OCD, obsessive compulsive disorder. In order for you to be diagnosed with this disorder, you must have obsessions, obsessive thoughts. And these obsessive thoughts will lead to what we call compulsive behaviors or compulsions. And we'll take a look at the duration and the severity in order for one to be actually diagnosed with OCD. So if you think that next time you see something on the wall that is slightly to the left or right and not straight, um, based on what we will understand right now, maybe you'll get a better understanding of whether you actually do have OCD or not. So, what are obsessions? Obsessions are intrusive, unwanted, and repetitive thoughts or urges, and they're commonly associated with anxiety. So, anxiety is a very important feature and symptom of OCD. It's this anxiety which is the main reason for the behaviors, the repetitive ritualistic behaviors that we commonly associate with OCD. Obsessions are thoughts that are intrusive and unwanted and repetitive. There are thoughts that keep coming in your head and you don't want them because they're causing you a lot of anxiety. Take an example of someone with contamination fear, which is a very common type of OCD, where you feel that you've come in contact with items that are contaminated. And these could be everyday items. For example, a door handle, for example, an elevator button, maybe your cell phone, maybe your iPad, maybe your laptop. So The person believes that they've come in contact with items that are contaminated, and now their hands are contaminated with germs. And this would lead to them perhaps falling extremely ill. And, if things worsen, it might just lead to their death. So this is an example of an extreme level of thinking that person goes through with OCD when they have these obsessive thoughts. And they can't control these thoughts. These thoughts just appear in their head repeatedly. And it's causing them so much anxiety because they're always thinking about the negative consequences. They're always thinking about the worst that could happen. So, what does the person do to deal with this anxiety, to deal with this stress and the difficulties of these unwanted, intrusive, internal, and anxiety inducing thoughts? So, in order to relieve themselves of this anxiety that they're experiencing because of these unwanted thoughts, they demonstrate a certain behavior. So, the behavior or the act that they demonstrate is what we call a compulsion, a compulsive behavior. Why is it a compulsion? Because they feel it's something that they have to do in order to relieve them of the anxiety that these obsessive thoughts are causing them. So let's go back to the example of contamination fear. If the obsessive thought is that your hands are contaminated with germs, the obvious solution to that would be to go and wash your hands. But over here, we're not just saying washing your hands for like a minute or so with soap. We are saying washing your hands for probably hours and multiple times a day. Because just because you've washed your hands and the anxiety of having contaminated hands is gone, it hasn't gone permanently. That unwanted obsessive thought will come back eventually. It might just come back immediately. It might come back after a few minutes, maybe a few hours, but it will return and the anxiety will come back and the person will again decide to go and wash their hands. And this process is repeated again and again and again for many days to the point where you're just not able to focus on any other aspect of your life as this is taking up majority of your time. Imagine if you had to go to work or school. If you're stuck washing your hands for 4 to 5 hours, you're not really going to be able to get dressed for school. And even if you do manage to somehow get to work or get to school, how are you going to concentrate on your work? How are you going to concentrate on your studies when this is all that you can think about? And if you're prevented from doing the compulsive behavior, the anxiety will only increase. So it's like this itch that you have that you just want to scratch, but you can't do anything about because you're in a situation which might make it difficult for you to constantly go to the washroom and wash your hands, which is why you would avoid going to public spaces, which is why you would rather stay at home and deal with the situation. At least in your mind you think you're dealing with it, but in reality it's just turning your behavior into a ritualistic repetitive behavior. So for that reason you will come across people with OCD who struggle to leave their homes and develop any sort of um, meaningful purpose to their lives because they're unable to work, they're unable to study. And it's very difficult. It's a very traumatic experience. And you got to feel for people who suffer from this disorder because you just have to imagine the anxiety that they go through. And it's not something that they enjoy doing, but it's something that they feel like they have to do, which is why we say it's a ritualistic behavior. It's so repetitive. The cycle is just repeated again and again and again. And the contamination fear is just one type. There are many other types. Um, you've got checking behavior. Often people with OCD might think that they've left their doors unlocked, or maybe they've left the stove or the gas on. And this thought is going to keep popping up in their mind again and again and again and cause them extreme levels of anxiety because they're probably thinking, if I don't lock the door, someone's going to break in. If I don't shut the stove, then, my house will burn down. So the behavior, the compulsive behavior that they have to then do is to go and check. And they might check 20 times, 50 times, 100 times, maybe not even the whole day, maybe within a couple of hours. So this behavior is just repeated again and again and again. And this repetitive ritualistic behavior is OCD. Now, let's move on. It says an example would be that a person may imagine a loved one being involved in an accident and may become anxious, believing that their thoughts would make the accident more likely to happen in real life. Now, we'll take a look at different types of thoughts that you can go through. Um, And obviously, these aren't very rational thoughts. These are irrational thoughts. And we'll talk about this in the cognitive explanation of the disorder. But one type of irrational thought that people suffer from during OCD is thought event fusion, which is the idea that if you think that a certain event is going to happen, the more you think about it, the more likely you think it is actually going to happen. So that's another type of obsessive thought that people go through. It's called thought event fusion. And it causes a lot of anxiety because you can't help yourself from thinking about these negative things. And you feel that the more you think about it, the more likely this event is going to happen. And in most cases, it's going to be a negative event. So you will have to do something to avoid this from happening. And that could be something completely unrelated to the event. Maybe, for example, you think that every time you step out of the house, there's going to be a car accident. So in order to avoid that, you might have to walk up and down your stairs maybe 20 times before you leave the house. So, it's often like a superstition, but sometimes the compulsive behaviors aren't even directly related to the obsessive thoughts. I mean, yes, washing your hands because you think it's contaminated is a compulsive behavior that is linked to the obsessive thoughts. But in this latter example that I gave you, where you walk up and down the steps maybe 20 times before leaving the house to avoid any car accident, there's no link between the two. So that is also possible. So it's a possibility that your compulsive behaviors may have nothing to do with the obsessive thought, but in your mind, you believe that by doing this, it's going to stop the act from happening. It's going to help you relieve yourself of the anxiety of this obsessive thought. Now, for a diagnosis to be made, both obsessions and compulsions must occur more than an hour a day and must result in significant distress or impairment to one or more areas of functioning, such as your family life, social life, your occupation. If you're a student, then your studies, and so on. And here's a table with some examples of some common obsessions and some common compulsions. Now, note these compulsions aren't the direct behavior to relieve yourself of the anxiety of these obsessions. These are just some random examples. Fear of deliberately harming oneself, fear of illness or infection, um, fear of contamination is also one. Um, Strong desire for order and symmetry is a common one. And some common compulsive behaviors: frequent and excessive hand washing, putting things in order, checking things repeatedly, repeating words to oneself or repetitive counting, and so on. And you might even know someone with OCD. Maybe you have OCD tendencies. Maybe, you at one point in time in your life did have OCD. I mean, I look back at my childhood and I think that maybe I did have some OCD tendencies because I would do some repetitive behaviors. I would have these anxiety-inducing thoughts. The thought event fusion, um, obsessive thoughts would come to my head as a kid, and I would do the strangest things to prevent them from happening. So I believe that maybe when I was young, I probably did have to maybe a very small degree OCD. Um, but thankfully now I don't think I have it anymore. I remember when I was young, I had this need for numbers to be even numbers, like cricket scores. But then that for some reason, maybe the next month would switch to odd numbers. And there was no reason to it. It was just something that caused me a lot of anxiety if it wasn't an even number. And then later on, when I had these obsessive thoughts about odd numbers, even numbers would bother me. So yeah, maybe look back at your early years, childhood, and try to remember if you had any such behaviors that, or maybe even now, if you have any such symptoms that may be potentially pointing towards OCD, or if you know anyone who might be showing such symptoms, it would be a good idea to maybe get it diagnosed and get it checked. We'll take a look at an example study by Rappaport in 1989. This is a case study on a 14-year-old boy named Charles with OCD. Now, this poor kid has contamination fear. He believes specifically his obsessive thought is that he's got a sticky substance all over him and he needs to wash himself to get rid of the sticky substance. And he would spend 3 hours or more a day showering with an additional 2 hours getting dressed. So it just takes around 5 hours for him to get dressed, which is almost the exact same time that takes my wife to get dressed. And let's hope that she doesn't come across this video. Uh, he was a good student with an interest in sciences, but obviously with this routine, it was impossible for him to attend school because of this repetitive routine of his. and his academics obviously would take a hit. An example of his repetitive behavior would be holding the soap in one hand, putting it underwater, switching hands, and so on. So, seems like a pretty tough routine. His mother decided to finally contact Rappaport after his symptoms had been going on for 2 years. He'd been going in and out of hospital for his condition and been receiving standard treatment such as medication, behavioral therapy, psychotherapy. So basically everything try, relieve him of his symptoms. As I said, he had this obsessive thought that there was something sticky on his skin that he needed to wash off. His mother tried to help him by using rubbing alcohol to clean items in his room to try and reduce his obsessive thoughts and compulsive behaviors. Now, he was given the tricyclic drug. Tricyclic, you guys should try and remember from the mood disorder chapter. Speaking of OCD, here's my cat with a very repetitive behavior of constantly coming and asking for treats. And she's not going to get any right now because she's been stuffing her face since the morning. Anyways, she wants to sit and study OCD with us, so she'll give us company. So clomipramine is the name of the tricyclic drug that was administered to this boy. And it did help him, or did give him temporary relief. But temporary, why? Because a year later, he developed tolerance to the medication. And that's the biggest issue with medication. It's not a permanent solution. Eventually, you build tolerance and it doesn't have that same effect that it maybe initially did. And unfortunately, this boy relapsed and went back to his ritualistic behavior of washing and dressing. Now, how do you measure OCD? You've got this section in the diagnostic criteria of every chapter. We call it the measures, and there's a diagnostic assessment in the form of a questionnaire, close-ended questionnaire. Like you had the BDI in the mood disorder chapter. You've got the kleptomania symptom assessment scale in the impulse control chapter. Typically, you've got one measure, but in this chapter, you have two. So you've got two ways of assessing for symptoms and the severity of OCD. The first one is the MOCI. So this is a questionnaire with 30 items, and you just have to select true or false for each of the 30 items. And these 30 items are split into 4 categories. So you'll have items on checking behavior, washing behavior, slowness, doubting, etc. So 4 types of behaviors that we associate with OCD. Takes around 5 minutes to complete. And depending on your responses, you get anything from a score of 0 to 30. And obviously, the higher the score, the more severe your symptoms. And here's an example of an item for each category. For checking, it says, I frequently have to check things such as gas, water taps, doors several times. So if you say true, then obviously you'll get 1 point. If you say false, then you won't get a point, because if you select a response that is indicating OCD behavior, then you will get a score. I'm not unduly concerned about germs and diseases. That's on washing. I do not take a long time to dress in the morning. That's on slowness. Even when I do something very carefully, I often feel that it is not quite right, doubting. So true or false for these different items. You've got 30 items. 30 was it? Yeah, 30 items. And then you just add your score and then you see what your score is. And the higher the score, the more severe your symptoms. Now, the other one, the more common one that is used is the Y box. And this is used in the chapter of impulse control disorder, where they modified the Y box to assess for symptoms of pathological gambling in the key study by Grant. But over here, this is not a modified version. This is the original Y box that is used to originally measure symptoms of OCD. It is a 10-item scale. You begin by going through a 30-minute semi-structured interview. And then you take this 10-item self-report where you rate 5 obsessions and 5 compulsions from a scale of 0 to 4. 0 being no symptoms, 4 being severe. And then you add your scores. And if you get a score from 8 to 15, that's considered mild OCD. 16 is the minimum score you need to be diagnosed for clinical OCD. 16 to 23 is moderate, 24 to 31 is severe, and 32 to 40 is extreme. And examples of items on obsessions are on aggression, contamination obsessions, sexual obsessions, hoarding, etc. And then compulsive behavior items could be on categories such as cleaning, washing, checking, repeating, etc. Here's an example of one. You should know this. How much of your time is occupied by obsessive thoughts? If you say none, then you get a score of 0. If you say less than an hour a day, it's a score of 1. 1 to 3 hours a day is 2. 3 to 8 hours a day is 3. And more than 8 hours a day, which is quite insane, is score of 4. So again, the higher the score, the more severe your condition. And obviously, the strengths weaknesses are the same as any other close-ended psychometric scale. It's a limited scale, 0 to 4. The MOCI also has just 2 options, true or false. Lacks qualitative data, but it's standardized and it provides a lot of quantitative data that's useful for comparison over time. Okay, moving on to the explanations. Now, typically we have 3 to 4 explanations in each chapter. But this chapter is an exception. This is the one chapter that has 5 explanations, 2 under the biological section and 3 for psychological, but they're not very long. And it's not like you have very detailed example studies. In fact, in the biological explanations, just like for schizophrenia, if you remember the chapter on schizophrenia, you just have slight pieces of evidence for why or how there's a biochemical or a genetic explanation for OCD. So let's take a look at the biochemical explanation first. And under biochemical, we'll obviously be taking a look at the role that different neurotransmitters have to play. Dopamine, serotonin, etc. are the most common ones, but we'll also see whether oxytocin has any impact. You probably remember oxytocin from your AS syllabus, the Perry study. Oxytocin is a social hormone that has a very important role to play in social bonding, in attachment, in trust, as well as fear and mistrust or distrust. So let's see what the biochemical explanation says. Research has shown that those with OCD tend to have abnormally high levels of dopamine. What's the evidence of this? Zetchman 1988 or 1998 found that when dopamine was increased in lab rats, they started showing repetitive movements. So based on this theory, if rats are showing repetitive movements because of high levels of dopamine, then maybe humans are showing repetitive behaviors that we see in OCD because of high levels of dopamine. So we're just kind of comparing what we saw in lab rats to humans because the behavior is similar. So maybe the reason or the origin is the high level of dopamine, but no real conclusive evidence to say that this is the case. What about serotonin? Now, serotonin, remember from the chapter on mood disorders, is responsible for regulating anxiety. And when serotonin levels are low, anxiety is high. And anxiety is high when you have OCD because of the obsessive thoughts that you go through. So it would make sense that the serotonin level would be low, which is why the anxiety is high. And the evidence to suggest that serotonin levels are low that causes the anxiety to rise, which can result in OCD, is seen in the fact that participants or patients with OCD are often administered SSRIs. SSRIs were the drugs that increase serotonin levels. It's given to patients with depression. It can also be given to patients with OCD. And it's shown that it's a useful drug treatment to help reduce the anxiety that people go through during OCD. So it does help to reduce the symptoms, suggesting that a major reason for OCD could be low levels of serotonin. What about oxytocin? So Leckman found that some forms, not all, but some forms of OCD were related to oxytocin dysfunction. So maybe low levels of oxytocin could result in OCD. But Denboer and Westenberg found no evidence of any link between OCD and oxytocin. In fact, they conducted a double-blind placebo-controlled study, which means that participants, there were 12 patients, half were randomly allocated to the placebo group and half were allocated to the oxytocin group, where they were given this synthetic form of oxytocin called syntocinon. And it is a double-blind technique to remove demand characteristics and researcher bias. The participants were given the placebo or the syntocinon synthetic oxytocin through a daily nasal spray, and they found that there was no reduction in symptoms reported by either group. So they didn't find any evidence to suggest that low levels of oxytocin is responsible for OCD. But in 2003, Hollander found that oxytocin, when administered through nasal drops, does in fact help reduce symptoms of repetitive behaviors found in people with autism. Now, people with autism also show repetitive behaviors, but the thing is that um, when these autistic individuals were administered this oxytocin through nasal sprays, it helped them reduce their repetitive behaviors. So Hollander is trying to generalize this to OCD and is assuming that, okay, you know what? If we can reduce the repetitive behaviors of autism through oxytocin, then it should technically also help reduce the repetitive behaviors of OCD. But this theory was proven to be inaccurate by Humble in 2013, who actually showed that high levels of oxytocin are associated with more severe OCD symptoms, particularly people who develop the disorder at a young age and are resistant to treatment. So this was the biochemical explanation. Obviously, they favor the nature side of the nature-nurture debate, and it's also deterministic at the same time being reductionist because it's only looking at the role of neurotransmitters. Now, when you talk about the genetic explanation, we look at two things. One would obviously be within family members. So if your sibling has it, if you're a twin, identical, non-identical, MZ, DZ. Remember monozygotic, dizygotic twins? Monozygotic twins are those that share 100% of the DNA and they're identical, whereas dizygotic or DZ twins share 50% of their DNA and are non-identical. Um, so if an identical twin has the disorder, what is the concordance rate or the probability or the chance that the other twin will develop the disorder as well? So that's what we're going to be looking at in the genetic studies or the genetic evidence. Also, what is the likelihood that if you have it, then someone else, like a sibling or a parent in your family, has it? And the other thing in genetics is specific genes, such as serotonin genes, because in the biochemical explanation, we discussed the role of serotonin and how low levels of serotonin can cause high levels of anxiety, which is associated with OCD. So, what is the reason for this low level of serotonin in these individuals with OCD? Is it response? Is this because of certain serotonin genes, such as um, the SERT gene, which is commonly associated with regulating levels of serotonin in the human body? So we'll take a look at that as well in this genetic explanation. Now, Manzani in 2014 carried out a large-scale twin study, and he found a higher concordance rate in MZ twins than DZ twins, with 52% concordance for MZ twins, meaning that if one twin has OCD, then there is a 52% chance that their identical twin will also most likely develop the disorder. And this is much lower for non-identical DZ twins, around 21%. And the general genetic link was around 48% among siblings. Now, talking about specific genes, so the SERT gene has been shown to have a role to play in the development of OCD. And this was found by Ozaki in 2003. So through DNA testing on 6 members of 2 unrelated families who had OCD, he found that these people with OCD did have a mutation in their serotonin SERT gene, which was the reason for their serotonin levels being lower, hence causing them the anxiety-inducing thoughts um, or the anxiety that led to perhaps the obsessive thoughts and compulsive behaviors. So this is the evidence that Ozaki is providing us with to suggest that there are certain serotonin genes that may play a role, or mutation in these serotonin genes that may play a role in the development of OCD. Matthijssen also looked at the role of certain genes, specifically 2 genes that he found to have a role in the development of OCD, the PTPRD and the SLITRK3 genes. And he found this by doing a study on 1,400 patients with OCD, as well as other members of the general population. Lewis in 1936 found 37% of people with OCD had at least one parent who also had the disorder, and 22% also had a sibling with the disorder. So it is, if one person does have it, there's a chance that others in the family may also have it. And lastly, it wouldn't be, sibling twin studies without Gottsman. But Manzani was a more recent study. This was a 1981 study by Gottsman, where the concordance rate that he found was much higher in MZ twins of 87% and around 47% in DZ twins. So this is the evidence to suggest that it is genetic. And just like the biochemical explanation, this too is favoring the nature side, and this too is also deterministic. Now let's talk about the three psychological explanations, beginning with cognitive, thinking error. Now, every time we discuss the cognitive explanation of any disorder, it's always going to assume that this is down to irrational thoughts. So schizophrenia was because the psychological explanation suggests that its symptoms are there because the individual has an irrational way of interpreting their thoughts, which are actually internal, but they believe that it's coming from an external source, hence the reason for their delusions and hallucinations. Similarly, in depression, again, it's down to irrational thinking because the person believes that they are guilty and anything negative that happens is because of them, and there is no hope. And, it's a very irrational way of thinking and a very negative and pessimistic way of thinking, which is not, um, you know, based on any logic whatsoever. So similarly, the psychological or the cognitive explanation of OCD is also down to thinking error, irrational thinking. So the obsessive thoughts that the person is going through, if you really think about it, is it really that extreme? Can holding maybe your cell phone actually cause you to die because of being hands being contaminated with germs and eventually falling sick? I mean, the likelihood of that happening is very, very low. So the person thinking about this constantly, you can understand why it's a thinking error, why it's an irrational thought. So Rachman is saying that obsessive thinking is caused by faulty reasoning. For instance, the belief that one's hands are covered in harmful germs that could kill could be the cause of irrational thinking. And these irrational thoughts worsen in stressful situations. So when you are stressed because of these anxiety-inducing irrational thoughts, what do? You have to engage in compulsive acts, compulsive behaviors. And when these compulsive behaviors become repetitive and ritualistic, that's how OCD develops. And then there are two specific types of thinking errors: thought action fusion and thought event fusion. Thought event fusion we've discussed. It's the second one over here. It says it's a belief that imagining a certain situation or event will make it more likely to occur. So the more likely you think that, the more you think about something negative happening, the more likely you think it's actually going to happen. So you need to do something to avoid it, like maybe walk up and down the steps 20 times. Thought action fusion is another type of thinking error. This is when people who have OCD symptoms believe that imagining behaving in a certain way increases the probability that you will actually behave this way. So the more you imagine that you will behave a certain way, the more likely you think you will actually do it. So almost like you're manifesting it in a way. But again, this is an irrational way of thinking. Just because you're thinking about something does not necessarily mean it's going to happen or that you have to behave that way. So both of these are forms of irrational thoughts that people with OCD symptoms often experience. Now let's talk about the behavioral explanation, which is the second psychological explanation. Now over here, we talk about operant conditioning. You're probably familiar with positive reinforcement, which is rewarding a behavior. So when you want a dog to maybe play fetch, you give it a treat, which is positive reinforcement. It's a reward. The other thing that you can do is punishment. If the dog doesn't listen to you, you scold the dog. A third type of learning technique in operant conditioning, which isn't often covered in AS or in A2 Upton-List chapter, is negative reinforcement. And people mistakenly confuse punishment with negative reinforcement, but it's not the same thing. Just because positive reinforcement is reward, that doesn't mean negative reinforcement is punishment. So you've got three things: reward, which is positive reinforcement, punishment, and negative reinforcement. Negative reinforcement is when there is a negative stimulus in your environment that is hindering your behavior. And when that negative stimulus has been removed, it allows the individual to show the behavior that is desired. Now, I gave you the example of the dog. If you want the dog to play fetch, and every time he plays fetch, you reward him with a treat, that's reward. That's a positive reinforcer. If you want the dog to play fetch and he doesn't listen and you scold him, and that gets him to play fetch, that's punishment. But if the reason the dog is not playing is because you've put, collar around his neck and it's making him feel uncomfortable, then that is a negative stimulus in the dog's environment. It's a collar. The collar is something negative that the dog perceives that's hindering his behavior. By removing this collar, the dog will now be able to be more comfortable and play fetch. Now, the removal of the collar is not a reward. The reward is a treat, and neither is it a punishment. So, negative reinforcement is neither a reward nor a punishment, but instead the removal of something that the individual perceives as being negative in their environment. It's the removal of a negative stimulus that is initially hindering or stopping you from showing a behavior. And by removing this, it now allows you to show a certain behavior. So it's a way of learning by removing something negative from your environment. Now, how is this linked to OCD? So take, for example, someone with contamination fear. You think your hands are contaminated with germs. So you have a lot of anxiety. What do? You wash your hands. Washing your hands leads to what? It leads to clean hands. Clean hands can serve as a reward for this person. So the clean hands would be a positive reinforcer. So that would encourage them to repeat this behavior. Because every time you get rewarded, you want to repeat that behavior. So clean hands, which means no more anxiety, clean hands is going to be a positive reinforcer, which will urge the person to repeat that behavior in future, whenever they think that their hands are contaminated. So that's the positive reinforcement aspect. But what about the negative reinforcer? What is the negative stimulus in the person's mind? It's the fact that they think that there are germs on their hands. So if they want to concentrate on their work or if they want to be able to socialize, they're unable to do so. Why? Because all they can think about is the fact that their hands are contaminated with germs. So the negative stimulus is germs. It's stopping them from behaving normally. So what do? You wash your hands. And what have you done by washing your hands? You've removed the negative stimulus. So the patient or the person will think that in their mind, they've removed the negative stimulus of germs temporarily. So not only is it a reward that they've got clean hands, but it's also a negative reinforcer as the negative stimulus of germs has been removed, and this removes the anxiety that they were experiencing. And then the next time when they get these thoughts again, they've learned that by washing hands, not only does it feel rewarding, but it also removes the anxiety and removes the germs. So this then becomes a repetitive cycle. And this is how they learn this behavior, and it turns into OCD. And that is the behavioral explanation. And then we have the final explanation, which is psychodynamic. This is the third psychological explanation. This is by Freud. Now, in order to understand this explanation, we must first understand the psychodynamic theory by Freud. Now, Freud suggests that everyone goes through different stages of psychosexual development. So the first stage that we go through, according to Freud, is the oral stage, which is between 0 to 1 years of age. And this is where young children, babies are showing behaviors such as putting things in their mouth, biting, sucking on things, etc. So that's the oral stage. That is then followed by the anal stage, which is the stage where the child is toilet training, learning how to use the toilet, learning when it is and when it isn't appropriate to urinate and defecate. And this is followed by the phallic stage, which is when they're slightly older and they start being more aware of their genitals. And then there's a few more stages as you grow older and puberty and so on. The stage that we are concerned with when we talk about OCD, according to Freud's theory, is the anal stage. Now, before we explain how all of this is linked, there are three aspects of a human mind that we need to understand that Freud explains. And these are the id, the ego, and the superego. Now, according to Freud, our mind, our unconscious mind has three parts to it: the id, ego, and superego. And these shape our personality and our behaviors. And they basically make us who we are. And they play a very important role in our decision making. Now, the id is that part of our mind that is driven by instincts and desires, aggressive desires, sexual desires. And it's basically like a spoiled child part of our mind. And it doesn't think about consequences. It doesn't think about the future. It wants to achieve its desires in the present immediately. For example, as a student, you're studying, it's the id part of your mind, it's that part of your mind that will cause this desire within you to want to put your books away and maybe watch TV, or maybe go eat something, or maybe hang out with your friends, or use your phone or whatever. So obviously there are consequences if you do this, but the it doesn't care about those. It's like the spoiled child within you. So this is the part of your mind that is driven by instincts and driven by strong urges and a need for your desires to be fulfilled immediately. And when this is not met, when the desires of the id are not met and rather they're ignored or repressed, it causes anxiety, it causes frustration. And this frustration can build up over time. And if it's not resolved, it can cause problems to you in the future, especially during adulthood, especially if you become fixated in this phase. It can cause anxiety disorders, it can cause phobias, it can even cause OCD. So that is the id. The superego is another part of your mind that is based on um, morals and ethics. So it's that part of the mind that is um, driven by a need to fulfill, um, or it's basically that part of your personality that is driven by morals and by moral standards, and one that does think about the consequences, unlike the id. So there can often be a conflict between the id and the superego, which is where the ego comes into place. Now, the ego is the part of your mind that basically makes you who you are. Okay, it's the most realistic part of the mind that mediates between the two. It tries to fulfill the desires of the id, but also of the superego. So the superego would say, you know what? We need to study, because if we don't, we will fail the exam. And this is something that we need to do. So it's the more responsible part of your psychology. The ego, on the other hand, like I said, is the one that mediates between the two. So the ego will make you think, you know what? Let's study right now for an hour, hour and a half. So fulfilling the moral standards of the superego. And then we'll take a break, and then we can go and eat something and watch TV. So also fulfilling the desires of the id. So that's the role of the ego. Now, sometimes conflict can occur, and especially in children, because the ego and the superego develops much later on. So for children, especially at a very young age, the oral and the anal stage, the child is driven mostly by the id. But they don't have those moral standards just yet. So their behaviors, their personality is driven by the instincts and the urges of the id. And if their desires are not met, they become angry, they become frustrated. And that's why you see a lot of children, when they want something and you don't give them what they want, they become cranky, they become annoyed, they become frustrated, they become anxious, they start crying. And that leads to them fighting and arguing with their parents, and that leads to conflict. So this conflict that occurs can cause anxiety. So according to the psychodynamic theory by Freud, when the child is in the anal stage and they are learning how to toilet train, the parents of the child are the ones who are in control. They are the ones who are deciding how and when the child should urinate or defecate. Now, sometimes the child may not agree with this, and the child may want to regain control of the situation. So there can be conflict, which is why a lot of times during the toilet training phase, you will see it's difficult for parents to get their child to um, learn this initially, because there's conflict. The id of the child doesn't want to do it. The child wants control, not the parent. The child doesn't want the parent to have control. They want control over the situation. So they will resist. They will either refuse to urinate or defecate when they're supposed to, and they'll hold it in, or they will let it out at the time when they're not supposed to. So this conflict that occurs between the child and the parent causes anxiety. And it's all because of the id being repressed, the desires of the id not being fulfilled. Now, this is eventually resolved later on. But sometimes when the individual gets fixated in this state and this is not resolved, it can cause problems later on in adulthood. So, both, so it says these behaviors can lead to behavioral disturbances later on in life, as these obsessive thoughts from the id may disturb the ego to the extent that it may lead to compulsive cleaning and tidying rituals later in life to deal with early childhood trauma. So, when this is not dealt with at an early stage, it can stay in the back of the child's mind, in the subconscious mind, It can be traumatic for the child because this issue was not resolved. And later on, the body, the personality, the brain, the mind tries to deal with it by, um, you know, compensating for the lack of tidiness or neatness at an early age by making the person feel that they're constantly contaminated and, needing to wash their hands and clean themselves and tidy up. So obviously, those are symptoms we associate with OCD. So that is how the psychodynamic theory by Freud can explain the development of OCD. Far-fetched theory, there is no real evidence to suggest whether this is true, so it's all theoretical. And with that, we can talk about now the last section, the treatment and management. 3 phases to it. The biological treatment, which is the use of drugs. We've already discussed in the biochemical treatment the use of SSRIs, which increase the serotonin levels and reduce the anxiety. Now, is this even effective? A meta-analysis was conducted by Sumro. Meta-analysis is analyzing multiple studies. Sumro analyzed 17 studies that compared the use of SSRIs to placebos. All these studies combined included a total of 3,097 participants who were studied for 6 to 13 weeks. And by using the Y-box, we assessed any possible reduction in symptoms. And overall results showed that SSRIs were far more effective than the placebos in reducing symptoms of OCD. So SSRIs do help to increase the serotonin levels and reduce the anxiety associated with obsessive thoughts. And that in turn would then reduce the compulsive behaviors. The other are tricyclics, which are also used to increase serotonin, dopamine, and other happy chemicals in the brain. They're also used to treat OCD. And like I said earlier, in the diagnostic criteria, the example study by Charles, by Rappaport, the clomipramine drug that was given to Charles that initially did help him overcome his symptoms was a tricyclic. But he built tolerance to it and he relapsed and went back to his ritualistic behaviors. Okay, then we have 2 psychological treatments, and both of them are forms of CBT. This one is ERP, exposure and response prevention. It's very similar to the concept of behavioral exposure therapy that we covered in the button phobia study in AS, where the idea is that you, excuse me, the idea is that you expose the person to the stimulus that is causing them disgust or anxiety. And the more they are exposed to it, the more they handle it, the more they get used to it, the more they get habituated to it. And the more they get used to it, the less anxiety that they experience in its presence. And that can help them overcome their obsessive thoughts and compulsive behaviors. So Lemkul is looking at the effectiveness of ERP. He's doing a case study on a 12-year-old boy named Jason, who unfortunately suffers from both OCD and autism, which is very rare. Only 2% of children actually have both autism and OCD. And as I discussed earlier in the explanations, that there are similarities in the symptoms as both involve repetitive behaviors. So at times it can be difficult to distinguish between the repetitive behaviors of OCD and the repetitive behaviors of autism. Now, this boy had a normal level of IQ, and he suffered from contamination fear, excessive hand washing, counting, and checking behaviors. He would spend several hours a day in these repetitive ritualistic behaviors, and every time he was prevented from doing them, it caused him a lot of anxiety and frustration. Now, ERP is a form of therapy. It's got 3 phases to it. The first is where you collect information about the patient, mostly through interviews, observations, and so on. If it's a child, you can get information on the parents as well. Once you have information about the existing symptoms and the origin of the symptoms, the next phase is to actually conduct the therapist-initiated ERP, where the therapist will make the person go through or the patient go through a few exercises, exposure exercises, visualization exercises, depending on patient to patient. And they also teach you some coping strategies to help you deal with the exposure that they're going to make you go through, because the treatment itself can be difficult because you're going to be physically exposed to the stimulus that is causing you anxiety. So it's not easy. But with gradual exposure, the hope is that you eventually will get used to it and it won't cause you anxiety. And it helps if they're teaching you certain strategies, coping statements, coping strategies that will help you, that will ease the process of habituating yourself to the stimulus that is causing you anxiety. And lastly, generalization and relapse training. So reaching a point where you can now apply these techniques outside therapy in the real world, and hoping that it does not lead to relapse and you're able to reduce your symptoms to the point where you are no longer diagnosed with clinical OCD. So Jason attended 10 50-minute sessions of CBT over 16 weeks. Now, one of the sessions, or one type of session, involves visualizing yourself in a situation where you're surrounded by items that you think are contaminated, and placing yourself in that situation. And then, just like the button phobia study where the boy was asked to imagine that he's got buttons falling all over him, and the more he was able to do that, the more his anxiety eventually reduced. Now, the same concept was, or is, usually used in ERP as well, in the visualization exercises, but they had to modify the ERP on Jason because of his autism. He's unable to perform the visualization exercises as effectively. So because he struggled with that, they modified his ERP to remove the visualization exercises, and instead they used physical exposure, where he was exposed to items that he believed were contaminated, such as door handles, buttons, etc. So by making him handle these items that he believed were causing him anxiety or disgust, he was taught coping statements such as, I know nothing bad will happen. Do not let OCD be the boss. So just reassuring himself that he is in control and that this is not the worst thing and this is not that bad that he's making out to be in his mind. So this gradual and slow exposure, while reassuring himself with these coping statements, is helping him get used to the fact that, he does not have to experience anxiety when being exposed to these things. And with enough practice, both within and outside therapy, he can reach a point where eventually he might be able to actually handle these so-called contaminated items without feeling anxiety. And if he is able to reach this point and the anxiety has been reduced, then the obsessive thoughts will be reduced. And if you reduce the obsessive thoughts, it will reduce the need for the compulsive behaviors, the ritualistic repetitive behaviors. And upon completion of the therapy, when they made him take the Vibox, initially his score was in 18. 16 is the minimum for a diagnosis. He had 18. By the end of the study, it was down to 3, which is well within the normal range. And at a 3-month follow-up, his scores remained low. So his treatment was effective in the long run as well. He reported major improvements in his symptoms, as well as participation in school and social activities. So ERP was quite useful in treating him. And lastly, we have the key study, which is also CBT, talking therapy, trying to treat patients with OCD by making them realize that their thoughts are irrational, and trying to make them more aware that, if they're able to control their thoughts and realize that they don't have to experience the anxiety that their minds are making them believe that they're going through with these obsessive thoughts, it can help them reduce their compulsive, ritualistic, repetitive behaviors. So Lovell in 2006 wanted to compare the effectiveness of CBT offered in 2 different ways, either via telephone or face-to-face. He wanted to see which one would be more effective in reducing symptoms of OCD in 72 patients from Manchester, age 16 to 65. So they were randomly allocated to either the telephone group or the face-to-face group, 36 participants in each. Um, the ones who were in the face-to-face sessions had to go through 1-hour sessions, 10 in total, whereas those who were in the telephone session had to go through 8 weekly telephone call sessions that lasted 30 minutes each. Now, they assessed the symptoms through the Vibox. They also assessed for the depression levels, because anxiety and depression are commonly associated. So they used the BDI, and they wanted to see how satisfied the patients were in their respective treatment techniques. So how satisfied were you with your telephone sessions? How satisfied were you with your face-to-face sessions? So it was an independent measure design. And the way that they assessed for their satisfaction was through a client satisfaction questionnaire. Now, the details of this client satisfaction questionnaire can be asked of you in paper 4. So maybe I'll make a separate document, which I think I have already, but I'll share it with you guys later, that might have the details of the items in these questionnaires, because they can ask you about this in paper 4, not paper 3. And as I've said before, keep an eye out on the chapters that come in paper 3, because they will not be repeated in paper 4. So if OCD does come in paper 3, And they won't ask you specific things like this in paper 3 about items in the questionnaire. So if there is any question on OCD in paper 3, then you won't need to go over the specific details of these questionnaires for paper 4, because OCD will not come in paper 4. So at a 6-month post-treatment follow-up, the Y-box scale showed an improvement in symptoms for both groups. So there wasn't much of a significant difference in the two groups. Both experienced a reduction in their symptoms, and both participants seemed to be highly satisfied with their respective forms of therapy, suggesting that patients with OCD can benefit equally via CBT administered either face-to-face or telephone. Now, there were some participants that were excluded from the study for some particular reasons. So those who had comorbid substance misuse, if you had been diagnosed with clinical suicidality, or if you had been taking medication for depression or anxiety in the last 3 months, because then this would act as a confounding variable. So you should know this as well, because this has been asked of students before in a recent exam. Not a very large sample, generalizability is low. It's an independent measure design, so there can be individual differences. Maybe one group has more severe symptoms than the other, so maybe the reduction in symptoms relative from one group to the other is more or less. But again, we don't know for sure, because again, individual differences are not being factored into the study, so that could affect the validity. What else do we have? It's nurture, because CBT is always about learning. It's not nature. It's, I guess you can say, you can even talk about the application, because both are useful. Telephone is more convenient. You can be at the comfort of your own home. Some people may be a little shy to talk about their problems face to face, so this would be an easy option for them. Face to face, on the other hand, also has high applicability, because it feels more personal. You're able to discuss your problems in more details, perhaps. Sometimes it might not be very clear via telephone call. So just some practical strengths and weaknesses of the two methods. All right, so I hope this was useful. Link to my WhatsApp group in the description. You can join it. There's one for AS, one for A2, and the Google Drive link with all my notes for AS and A2 will be written in the description of these WhatsApp groups, so feel free to join. And if you have any questions, then join the group. My contact number is and my email ID is present in the very first slide of this chapter. So I hope this was helpful to you guys. And once again, apologies for the very long break and delay in posting this video. But better late than never. And anxiety next. So I'm going to try and upload that very soon as well. And then I'll start working on health. Okay. Thank you guys. Bye-bye, and see you very soon.